So where would you like to begin? Where would
The
this start?
place I feel like I would like to begin is how did we get here? So like for a little bit of context of just like the personal experience I'm bringing to this conversation. I'm a child of Salvadoran immigrants. They literally fled the Civil War in order to, searching for a better life in the United States. And what's kind of stunning for me is that like a lot of my family members right now go back to El Salvador to get like procedures and stuff done, just because it is so much cheaper. Um, my mother has like asthmatic issues, and it's just insane how high these bills kind of get for ER visits and stuff like that, where we've just barely been able to kind of be able to pay off the bills, luckily. But we know that that's definitely a thing of luck because there's many families who can't. So how did the US kind of end up in this predicament where healthcare is so explosively expensive for us, especially compared to other industrialized nations?
Yeah, I think a good place to start would be about 100 years ago. We've always had this back and forth between whether we want to focus on individuals taking responsibility for themselves or whether society has some role in the responsibility of all the members of the country. And so about 20 years ago, the unions, the early unions, because unions were just beginning to form in the 1920s, they were starting to demand benefits for their employees. And one of the things they talked about was health care for their employees. So if you go back 100 years ago, there really wasn't even private health insurance in this country. You were literally on your own. No Social Security, no Medicare, and no private insurance. So over time, there's this back and forth yin and yang between, do we provide health care to all the people of the country, which is what many of the unions were fighting for, which I call myself a liberal, but I guess nowadays the proper term would be progressive in terms of thinking towards the future. So people who were the liberal progressive bent were thinking, how do we help all members of society? And of course, like any kind of social issue, they put forth their ideas, went to Congress, tried to influence Congress to passing legislation. They came very close in the 1940s, when 1930s and 40s, when the Democrats were in power and FDR was the president. But they had just too much on their plate with World War II and other social issues. So Roosevelt asked members of his cabinet, what can we do to address the issue of health care? But I don't want to get into a political fight about this. So what they did is they came up with the idea of allowing the private enterprise, private organizations to offer health care insurance, and it would be tax deferred. So in other words, if you bought health care, and keep in mind, there wasn't a lot of health care insurance to be had to begin with. But if you were a private business and you wanted to provide health care to your employees, you could do that, and you could have the advantage of deferring those costs in terms of your taxation. Well, again, this is the 1940s during the war, in late 1940s, it was very slow to happen. But interestingly enough, after the war, it started growing and growing and growing, and more companies started offering private health care insurance because it was profitable. And I look back at it from when I was a child. I didn't think, as a child, you don't think about it. But for probably until I was in junior high school in the 1960s, my parents did not have health care insurance. It was all out-of-pocket expenses. Yeah, and that was true for probably most Americans. You paid for it out of pocket. You were lucky if you had a job with health care insurance. And it wasn't until maybe the mid-1960s that both of my parents had jobs where the job included health care insurance as a benefit. So it's been a very slow climb. And the fight for universal health care has never really ended since then. And of course, the big fight was in the 1960s when Medicare was proposed and Medicaid was proposed, and both passed. It was an interesting thing. Medicare and Medicaid passed primarily as Democratic bills under Democratic presidents, but they did have some support from Republicans, particularly Republicans in the Senate. So if you were to look at it for example, today in the way the composition of our Congress is now, it's one of those things where sure, we could get universal health care passed through the House of Representatives. It would never pass the Senate because we have a Republican majority. Back then, I think it was popular because they saw it as something that was advantageous to seniors. And before Medicare, as far as healthcare was for seniors, I mean, it was either you had insurance, private insurance, which would be very expensive, or you didn't, and the majority of seniors didn't have it. So following that, there was this continuous attempt to pass some form of healthcare, universal healthcare in this country, back in the 70s, 80s, and into the 90s. Kennedy, I'm trying to remember which one. Senator Kennedy. I can't think of his first name. That's terrible. But he proposed a number of times legislation to provide universal health care, and came very close but never got it. And of course, in the 1990s, Bill Clinton proposed universal health care, got really close to it, and actually got the health insurance industry on his side. And a lot of people were for it. And then they decided, well, maybe this isn't too advantageous for us. Republicans were opposed to it. And so they mounted a major propaganda effort to oppose the legislation. And it won, and they weren't able to oppose the legislation. They actually had ads out where they had this couple, Harry and Louise, and they would say, "Oh, what's going to happen to us if the government provides health care? We'll lose all our, health care benefits. The health care won't be as good as we have now. Won't pay for all these things. This is a terrible piece of legislation." And it was very, very effective advertising. And so if you look at the history of it, the Clinton administration came very close to actually passing universal health care in this country. But the opposition was more powerful, and it failed. So then, of course, we have the Patient Protection Affordable Care Act, which was passed right after Obama was elected. And if you look at the Affordable Care Act, it's somewhat of a balance. He didn't want to take on the insurance industry. So what the Affordable Care Act does is it created a pool for insurance companies to offer the healthcare insurance and compete. Apologize for the phone. We'll let it. So the idea was we won't fight the healthcare insurance industry. We'll bring the insurance industry into this. Mm-hmm. So they have the insurance pools where you can go in and purchase insurance, and there is some regulation of that in terms of costs, and that has been very positive in terms of expanding healthcare insurance. I would say probably the most effective way of expanding healthcare insurance in this country has been through Medicaid expansion. And that is where the federal government will help subsidize the cost for Medicaid along with the states to people who are low income in terms of their economic status. And interestingly enough, it's expanded healthcare insurance to people that are, we would call the working poor, mm-hmm. where they're low-wage jobs where their employers can't afford to provide them healthcare insurance. Not that the employer wouldn't want to if they could, but they can't afford to. The thing that comes to mind is like home health care aides, mm-hmm. okay, where they're very low paid. They most of them work for small companies, and the companies can't afford, even with the tax breaks, they can't afford to offer it. So the interesting thing there was that has worked in terms of expanding access to Medicaid and thus low-cost health care for millions of Americans. When I wrote the book, there were 18 states that still had refused to expand Medicaid, and I believe now it's down to 16 states. And those were all states with Republican governors and Republican legislatures. It is very much a partisan issue, and they will not expand it and offer their citizens of their states health care based purely on political reasons. There's really not much else, other reason why to do that. And the reason I say that is here in Virginia, we were one of those states. We didn't expand Medicaid until 2 years ago. The Democrats won both houses. And the first thing they did, as soon as they won both houses, is they expanded Medicaid.
Mm.
So thanks to that, we actually now have about 90% of Americans have some form of health care. But that still leaves about 25 million Americans without it. And of course, with the COVID-19 pandemic, people have lost their jobs. And so the number of Americans with health care has been increasing during the pandemic. So there's been a long history of trying to get there. And it's been I guess maybe one step forward, 3 or 4 steps back during the past 100 years. We're slowly getting there. Where we are now, and I think we are very close to a tipping point, but we're still not there yet. Mm-hmm. And by that I mean the cost of healthcare insurance premiums keep going up. Mm-hmm. They're going up for employers and they're going up for individuals. And to counterbalance those higher costs, the healthcare insurance industry is offering more and more policies that are high deductibles. Mm-hmm. So, you're responsible for the first 500. Well, to get lower premium rates, now you may be responsible for the first 2,500 mm-hmm. or the first $4,000. Or this amazed me. I was talking to my doctor, and I said to him, what do you think of universal health care? And he says, well, right now we're paying a health care plan for our employees of $10,000 per premium per employee.
Whoa.
And I said, you got to be kidding me. And he said, no. And the nurse piped in. She says, yes. Said, they are. Says, the doctors are underwriting the costs for us, the office staff and the clinical staff, the nurses, but the doctors, they're paying $10,000 per premium for the healthcare insurance. So yeah, I don't know where they're getting their healthcare. It seems to me a bit high to be paying, and I would like to think that there's alternatives, but I think we are getting to a point where healthcare costs are getting so high that we may reach a point where a lot of private businesses say, well, we've had enough. We can't afford to do this.
Can we dig a little bit deeper there? So you've talked a lot about just the history of people trying to get universal health care so far. One of the things that you said that, surprised me, that is something I learned, which is that there was a point in American history where like a ton of people didn't have health care insurance. And then you were talking about how you were raised with your parents who were kind of uninsured during that time, like most Americans at that time, right?
Right. Mm-hmm.
Yeah. So I guess there's kind of 2 questions there. One is, if most Americans were uninsured, what was kind of happening when people were getting sick and needing like expensive procedures? Were they just doomed? And then the question that also ties into is like, why have the healthcare costs gone up so radically?
Mm-hmm. And I think the answer to that is it's partly the same answer to both questions. If you go back 60 years, back to the 1960s, for example, we didn't have the medical technology that we have now. So that, of course, with more technology, more drugs, more medications, the costs are going up. That's part of the reason the costs are going up. And I think that's also part of the reason why, when you were ill back in those days, the treatment wasn't as effective. Mm-hmm. A really good example, childhood leukemia. Back in the 1950s, if a child was diagnosed with leukemia, it was a 99% certain chance that it would be mortal, that they really didn't have the treatment for. Mm-hmm. And the doctors, fortunately, the medical researchers and the doctors, the pediatricians who were treating children said, we can't live with this. Children should not be dying from this disease. So they started developing treatments. Some of those treatments were effective, some weren't. So over time, you started seeing, 75% mortality rate. Well, now we're down to a 50% mortality rate. Now we're down to a 40 or 30% mortality rate. Back in the 1970s, We had some friends whose child was diagnosed with leukemia, and that woman, now grown woman, is still alive because by the 1970s, the mortality rates had gone down to like 30%. Today, I think the mortality rate for childhood leukemia is probably below 15%. So you've had these advances in medical technology where we're really, push, and that's created much better outcomes in terms of helping people live longer, but they also come at a tremendous cost. We also do a lot of things. There's a lot of spending that's people question in terms of why healthcare is so expensive, like testing, and whether testing is effective, whether it's effective in terms of clinical outcomes and effective in terms of cost effectiveness. A real good example would be, I'll give you 3 examples. One would be colon cancer screening. We know that colonoscopy is very, very effective. It's both cost effective and it's clinically effective. And that's because when you have, you're too young to have had probably colonoscopy. I'm old enough to have had a few. And while it's not a very likable process, what happens is when they go in to do that, if they see polyps, they can remove them, precancerous polyps. So the rate of colon cancer has gone down significantly for those individuals who are comfortable enough to have colonoscopies. There are still a lot of people who feel uncomfortable with the idea of the procedure. We won't get into the technicalities of it.
That's neither here nor there.
But it's highly effective. So it's cost effective and it's clinically effective. Okay. Then you have something like mammography and the breast cancer screenings. That's questionable because it becomes more clinically effective in terms of clinical outcomes as women age, and that's because the incidence increases. So as the incidence increases and you're doing more of them, you are more likely to catch a breast cancer in older women. But breast cancer also happens in younger women, in women under 40, or at least by 40 or so on. So the question then becomes: do you screen everybody in order to find a few cancers? And the organizations that look at that have come out with different recommendations. Some have said the costs are worth the benefits. Even if it saves a few lives, let's do it. And some people say, well, costs aren't worth the benefits. There are too many false positives, and we shouldn't do this. So there's been, if you look at the history of, say, breast cancer screening, it's kind of gone back and forth. I think now the American Cancer Institute is recommending it for every woman over 45. It used to be every woman over 50. So I think but there's still controversial. And then there's a third test, again, one you probably haven't had, but I've had because of my age, and that's for prostate cancer. And that's an interesting one because it's neither what we call valid or reliable, but we do it anyway.
It's neither valid or reliable?
Right. The gentleman, the medical researcher who developed the PSA, the test for prostate cancer, said we should not be using this for mass screening. But it's the only thing we have to detect early. And the problem with it is it has huge numbers of false positives. But if you're one of those who has a positive and the screening works for you, then
that's a big deal.
Yeah, it's a big deal. I'm glad I had it. But if you're one of the many who had a false positive, then you may not be so happy.
Yeah, the unwarranted stress. Yeah.
Right. So but if you look at all 3 of those screening processes, they have various clinical outcomes, various results in terms of cost effectiveness. But in this country, we do a lot of them. And we do a lot of them even more so than they do in, say, European countries where they have universal healthcare. So that's one of the things that drives up the cost of healthcare. There's another thing that I think is really worth discussing, and that's pharmaceuticals. The United States, and I think it's New Zealand, are the only 2 countries that allow advertising of medications on television. No other country allows that. And guess who you have high rates of use of pharmaceuticals?
Yeah, that's probably New Zealand and us then.
Yeah, right. I was watching the evening news before this, and probably a third of the commercials were for medications. So yeah, so they know that seniors in particular watch television, and so they pitch drugs, for seniors. Like there's the medication for improving your memory,
Hmm.
and of course there's a little line underneath that says, the FDA has not approved
Yikes.
any of the claims in this commercial, but it's heavily advertised. So that also brings up the cost of healthcare in terms of, I would say, on the clinical end. Then there are lots of other things that are mitigating the cost of healthcare here, particularly in the United States. So yeah, our costs in this country are much, much higher than they are in other countries. There's a wonderful piece in Sicko, Michael Moore's video about healthcare, where he takes a group of people down to Cuba for healthcare.
I remember that. That was a very controversial part of the film.
But there are some things about that, if you get past all that, communism and socialist medicine, that are worth looking at. One is they focus very heavily on preventive medicine in their own population. So they work very hard to have healthy people. And I think that helps them, in terms of their clinical effectiveness down there. They also, interestingly enough, have more doctors per capita than the United States does.
Huh.
They've made medicine one of their big businesses. And in fact, one of the ways that they actually generate money for the country is that people go there for treatment.
Rather than other places. Yeah.
Yeah. So what they've done is they set up medical clinics solely for people to come from other countries to treat them, and the profits from those clinics go back into the revenues for the country. Helps them write their costs.
So I have two questions that are colliding with each other, but I kind of want to look at them separately. So I'll tackle the first one since we're talking about cost right now. One of the compelling claims that you make in the book is that universal healthcare would cost less than what healthcare costs now. And I think that would be controversial, or not controversial, but counterintuitive for a lot of Americans to think about. That usually when you think about, even for people who support universal healthcare, they're thinking, yeah, my taxes will go up, but like it'll be worth it, I feel like, is what the average person is thinking when they're thinking universal healthcare. But you're making the case that it'll cost the country less overall. So can you speak about that?
Yeah, I think there are two aspects of that. The first one is we may pay more in taxes, because what I'm proposing is a healthcare tax, okay? And a lot of other, and I want to get to this too. I'm proposing multiple sources of revenue. Okay, the more those revenues are spread out across the population, the less it costs for the individual. So yes, those healthcare costs, those taxes and other costs will be there. But on the other hand, people won't be paying for healthcare insurance. So that's one aspect of it. I think it's a very important aspect of it. So let's supposing that you have a family plan, and that family plan is costing your employer $1,400 a month, and they pay $800 and you pay $600. Okay. Under the plan that I'm proposing, which is a single payer system, that business will no longer have to pay the $1,400. Now, when I say they're paying the $1,400, the reason I'm saying they're paying the $1,400 is they're paying their $800 share, right? But they're also paying you your salary. So that $600 that's being taken out of your paycheck is actually $600 that company is paying you. That's their money. So in the long run, it's going to save your employer $1,400 per employee per month. So it's a big benefit to employers, but also it's saving you $600. So while you may have to pay taxes and other fees along the way, you're also bringing home $600 more a month. So that's one reason why I think it'll be more cost effective for both employers and employees. The other is when you stop and think about how we're paying for healthcare now. So we have the private insurance market, and a large part of all this through the employer-based insurance and through the insurance markets, insurance exchanges. But you also have Medicare, you have Medicaid, you have TRICARE, you have CHIP, which is the Children's Health Insurance Program. So those are 4 programs that the government runs directly through taxes. And they're serving millions and millions of people.
Mm-hmm.
Okay. But then you also have federal employees and their families, state employees and their families, city and county employees and their families. And those are millions and millions of people where their health care insurance is also being paid for through taxes. So it turns out that half of the people in the United States are already getting tax-supported health care. We might say that we do have a semi-universal healthcare system, and that half of the country is already getting their health care through a tax program. Now, the other thing is when you have single payer, and this is the main opposition you get from obviously insurance companies. The plan that I'm recommending, and similar to what others like Bernie Sanders has recommended, is that when you have single payer, you have one government program similar to Medicaid, Medicare, where all the revenues go into the program, and that program then pays the practitioners, the medical practices, the hospitals, and the doctors, and physical therapists, and so on. It's one single insurance plan, not Aetna, not Anthem, not United Healthcare, not this plan, not that plan. And the advantage to that is when your doctor you go to the doctor and they say, well, what healthcare insurance do you have? Every one of those healthcare insurances have different rates for the doctor. In other words, they're being reimbursed a different rate by each different healthcare insurance company. And they have different forms to fill out for every healthcare insurance plan. And they have to have staff that know what the rates are and what insurance plan. When you have single payer, that's no longer there. And so they talk a lot about reducing administrative costs. That's what they're talking about. They're talking about you wouldn't need all that. Basically, in the plan that I'm proposing, is you walk in, you hand the doctor your health care card, they scan it, and that's it. You're never asked anything about what health care insurance you have, and there in the office, they don't have to worry about it. When the doctor sees you, he makes a diagnosis, he's typing up his notes, and when he types up his notes, he codes what he's done, which is actually what happens today. There are codes that they use for each diagnosis. He does that code, he hits transmit, it automatically goes to the national insurance plan, healthcare insurance plan. They get it, they review it, they pay them. So you reduce all those overhead costs. So that's another reason why there's a belief that we can really lower the cost of healthcare through the lower administrative costs. And the estimates there vary, but they typically run somewhere between a savings of $250 to $500 million a year. Now, obviously, if you are an executive with Blue Cross Blue Shield, you're not going to be happy with this plan. But my argument is, if you are the Walton family and you own Walmart, or you're Jeff Bezos and you own Amazon, and you can save tens to hundreds of millions of dollars in healthcare costs, why wouldn't you be for it? So I think ultimately the cost savings for the private sector could very much be the tipping point more than anything else. I think the private sector will say, we can't afford not to do this. And I think that'll get to the point where they'll basically, the private sector, the Jeff Bezos of the world, will be saying to Congress, no, we don't really care about the profits that the health insurance industry is making. We care about our own profits.
So that kind of, I want to take this, there's kind of the second prong to the question I had, which is, so like part of the conversation with universal healthcare is about like what economic philosophy that you're kind of advocate for, whether you think it should all be free market and privatized, or whether you're okay with like these socialist elements kind of dipping in and providing healthcare. But as I was reading your book, I realized that that's only like one prong of like the issues that are like American healthcare system is facing. And one of the things that you had mentioned pharmaceuticals, with that being something that's so heavy and problematic in our country. And one of the lenses I kind of want to look at that through was through the opioid crisis. So is that something that the American healthcare system kind of created versus like, or was that a global phenomenon is like a question that's popping in my head right now. And then how is the way we approach just healthcare in general leading to things like that?
Okay. With the opioid crisis, I don't know the entire story behind it, but I think, one thing is, I think certainly was that the companies that were manufacturing the opioids as painkillers were heavily marketing that to physicians. And that's something else that's unique here in the United States, is the marketing of medications to physicians. In fact, traditionally, the pharmaceutical companies marketed to physicians, but not to the general public. And beginning in the 1990s, they realized that they could increase their sales if they marketed directly to the public. So you got to a point where basically people were going to their doctors and saying, I have a backache, I think I need XYZ medication. And the physician was kind of put in the position of saying, well, I don't know that you really need that. And then the person says, well, if you won't give it to me, I'll go to another doctor who will. So in terms of the opioids, they were being marketed as painkillers, and particularly as safe, not addictive painkillers, which wasn't true. And so that helped create, I think, the opioid epidemic that we have. But there was another question, part of that, I'm trying to remember what you'd asked.
Yeah, and I think it just comes to like the way the American healthcare system approaches health and medicine kind of philosophically, right? There's this section on the book where you talk about holistic care. And I feel that's a part of it, right? Like that's something we should be moving towards, or that you would argue we should move towards. And what's the difference between how we treat stuff in the US now?
Well, I think, I particularly like Western style medicine in terms of what we do in terms of medical research. I don't want to pray my way out of the pandemic. I would prefer to have a vaccine. But if we're talking about holistic medicine, what we're talking about is looking at trying to better understand what's going on with people, what their healthcare needs are, matching the healthcare with individuals. I want to go back to something, though, going back to the opioid crisis, because I just remember what you were asking in terms of better control of that, or how can we deal with that. Part of that is a process called utilization review, which is basically looking at what are the practice patterns of healthcare practitioners. And what research has found is that, and I think it answers also the other question you asked, is healthcare medicine in this country is both an art and a science. And I think most physicians would probably agree to that. It's science-based where it can be. But there's also some intuition and a lot of experience going on. Really good example would be the more operations the doctor does of a particular procedure, the better they get at it. Okay, so there's evidence that that's very important in terms of experience. So it doesn't mean that you don't want to go to a young doctor, but experience does matter in terms of making diagnosis and carrying out procedures. But you also can look at what's going on, and what you see is you could have the same problem I'm having, and you go to a doctor there in Salt Lake City, and he prescribes X, Y, and Z, and I go to a doctor here in Virginia, and he prescribes ABC. Okay, so you don't have, they're not always, because it's an art and a science, you don't have that continuity. And so that's one of the ways you can look at that is practice patterns. And one of the things that I have in my plan is there would be more utilization review. If there had been better utilization review in regard to opioids, you would have seen those doctors much more quickly who were prescribing large doses of opioids, because that's basically how you find them in the end, is you look at their prescription and practice patterns. So that's one way that you can control that. No system is perfect. There's one thing I like to say is we're human beings. We're not perfect in any way, and any system that we developed is going to have problems. But it is an approach to looking at how we utilize medicine in this country. So yeah, that would be one way of addressing the high costs, is through this utilization review to see how doctors are prescribing. And one of the ways that I suggest that we deal with that is if you see, for example, that there's a doctor who every time a certain situation comes up, he prescribes a particular test, but the evidence doesn't show that the test is all that effective. Okay. Then you have, in the healthcare system, there would be a program where the doctor, another physician would call that doctor and say, we've been reviewing your practice patterns, the things that you're billing for. And we find that you're billing for something that we don't consider to be evidence-based. Mm-hmm. And so we want you to know that if you continue to do this, we may not be reimbursing you. On the other hand, we're going to send you this literature on what we consider to be the best practice for these things. We want to encourage you to start utilizing and looking at these procedures as an alternative to what you're doing. So it becomes more of an educational, collegial exchange where you're helping the physician move in a direction you want them to move in, rather than just, rapping them on the knuckles and saying, don't do that again. And that way, I think, overall, you begin to improve care in the country. As far as holistically, I think that's part of it. One part of it, for example, would be that now, and particularly under the Affordable Care Act, there's incentives for doctors. There's incentives for doctors to communicate with each other better, so that. And I saw this with my mother in her later years. She was in her late 90s, early 90s when she passed away. And towards the end, she was being seen by 3 or 4 different doctors. And they didn't always know what medications one doctor was prescribing and another doctor was prescribing. And so the more you do that, the more you increase the risk of drug interactions. And so under the Affordable Care Act, there's incentives for physicians from different private practices to communicate with each other. So when I go to see my primary care physician, he puts all the stuff together and he writes all the stuff up. But if I'm seeing a specialist, he sends my results to the specialist so that they know what's going on and they have a more complete medical history. So that's a way of being more holistic, and that there's better communication between your practitioners, and hopefully you're reducing risks, say from medications or other procedures.
Yeah, and I think this is leading me to a point, one of the most compelling points that I feel like was made during the evening ethics conversations, where essentially there was a group in the audience that was arguing that racism has a lot to do with why some Americans don't accept the universal healthcare proposals, being that there's like a subsection of like racist white people essentially who would be okay with not receiving universal health care if it means that they're not paying for like poor brown and black people to have it. And I guess the question I wanted to pose to you is, how do you see issues of race, issues of gender kind of intersecting with your arguments for universal health care? Keeping in mind things like, I was reading Travis Reeder's book on pain, and he talks about how, black people oftentimes don't get prescribed the painkillers that they need because doctors just assume that black people don't feel as much pain. The same with like the mortality rate of black mothers is much higher than, the mortality rate of white mothers and mothers from other races. So when we look at those realities, how do you see them fitting into your arguments for universal healthcare? Is there something that you address, or that's what my question is.
Yeah, well, 2 things. First is there is a long history of this in this country. When they went to pass Medicare in the 1960s, there was opposition from Republicans and from Southern Democrats, the Dixiecrats, against Medicare because it would be offered to all Americans, including Black Americans. So yeah, there's an underlying history of race definitely in providing healthcare. I think today it's a little bit different in that there's probably a legacy of the medical profession being primarily white men, and that's definitely changing. Today, 50% of all medical students are women, and I think close to
50?
50, yes.
Yeah. Oh.
50% of
For
all
how
medical,
long has it been like that?
well, for about a decade or so.
Huh.
Yeah, and the number of women in the medical profession is almost close to 50% now. Yeah, it's one of the
That's
professions.
heartening.
It is heartening, yeah. You know, sometimes my wife and I will have this, my discussion. She said, well, would you go to a urologist if it was a woman? And I said, I probably would. I don't know why I wouldn't. She's the doctor.
Mhm.
You have to be comfortable with that. And I don't think a lot of people would be comfortable with that. But yeah, so I think the medical profession itself is changing. But from a standpoint of research, there's a long history in this country where when you were putting together people for research projects, you would use white men. And so there wasn't a lot of research looking at what is the effect of this medication on women. And where you saw that, a really good example where you saw that before it became more cognizant of it, was the dosages. Because now I think most physicians recognize that doses should be based on a number of factors, including your body mass, in terms of how well you would absorb it, the medication, and also there may be gender differences. So you want to look to see if there are gender differences. That's one of the things that they're looking at with the COVID-19 vaccines. Would there be gender differences? Okay, would there be differences based on age? Because as you age, your immune system gets diminished. So, would you have higher mortality rates of seniors on the medication, or could the vaccine should be at lower dose, say for seniors and children? And I think, the same would be true with African Americans in terms of doing more study in terms of what are the impacts of these on not just, I think we can get beyond the issue of race here. I think the questions become, what are the impacts of these treatments on people based on multiple factors: gender, age, race, and other medical factors. So yeah, I think that there's definitely that needs to be done more, but that's I think a legacy of the medical profession being primarily white men up until the last decade or two.
And talking about COVID-19, I'm wondering how the U.S. healthcare system ability to respond to COVID-19 plays into your arguments for universal healthcare. How does it play in?
Yeah. I see the results, I see what's going on in this country to be very scary, quite honestly. When I started this project, I knew that there would always be a segment of society that say, well, we're comfortable taking care of ourselves. We don't want to take care of everybody else. I'm the breadwinner in the family. I'll go out, I'll buy the insurance, I'll take care of my family. You take care of your family. Everybody take care of themselves and we'll all be fine. And I thought, well, I will make the argument that that's all well and good, but the problem with that is that you're always going to have winners and losers in a system like that. And right now, when you have tens of millions of people without healthcare insurance, that's too many losers. I see the same thought process playing out with the virus right now, where so many people, for example, are saying, I'll take care of myself, and if I choose to wear a mask, I will. And if I don't choose to wear a mask, that's my decision. That and I'll be responsible for me. You do what you want to do. And it's we had in the ethics discussion this debate and discussion about where is that going to take us if we can't come to some agreement on public health and public safety, because the public in public health means everybody. And so, we want to make sure that we have a system where everybody can be safe and protected. And when people are out there saying, well, it's my right, I can do whatever I want, you can't make me do it, then the entire society suffers. It's quite different than when I was a child. When they came up with the polio vaccine, people were not saying, well, I'm not going to take this. I'm against this. I can remember as a child, we lined up in class and we got a shot in the arm. And when you're a child, you feel that pain more. So when they came out, that was the Salk vaccine. When they came out with the Sabin vaccine, they put the vaccine on a sugar cube, which probably was why my generation was the LSD generation. But they put that on the sugar cube, and I can remember standing in line at my junior high school where my parents and I and my brother all lined up with all the other families in the community, and we just walked down the line, and we all, took a sugar cube, and we all got vaccinated against polio. And there's virtually no polio in this country today. Polio is a virus, and I think people, and it's an example of a virus that we have control over because we vaccinate against it, just as there are so many other illnesses that we vaccinate against. But you can't get the response you need as a public health initiative unless everybody's going to be part of this. It's a very interesting dichotomy in terms of what Trump is saying, because on the other hand, he's promising voters he'll have a vaccine by the election, by the end of October. So he's saying, we're going to solve this, we're going to have a vaccine. And yet most of his supporters won't wear masks, and they're saying that they won't take the vaccine. And he's kind of going along with that, saying, well, it's your choice. So it's like, you're getting he's talking out of both sides of his mouth on this issue.
Mm-hmm. So speaking of politicians and stuff like that, have you had the opportunity to talk about this book with any politicians or decision makers who do have the power to change any of this? And how have those conversations gone, if you have?
Unfortunately, no, I haven't. And I'll tell you that I was very frustrated by this. I sent information about my book to every member of the Democratic committee in Congress involved in single payer, and not a single one of them responded. And I'm not sure why. I'm really not, right now, the politics are such that if Joe Biden wins, he has his approach, which would be to provide a public option, which basically would be in the healthcare exchanges, in addition to going out and looking at, there's a plan from United Healthcare, there's a plan from Blue Cross Blue Shield, there would be the public option, okay, which would be a tax subsidized health insurance plan. And so you would look at what's offered and what the costs are, and the idea is that the public option will cost less and that you'll go to the public option unless those private insurers bring their premium costs down. So in other words, it's to push competition in the market, which of course, even though Republicans like to talk about competition and a market-based economy, they don't want the competition because it would, cut into their profits. So that is the one approach that they have, and the idea being that, well, if you can get your insurance less costly from the government, then private exchanges. What about if I'm a businessman? What if I say to my employees, look, it's costing me $1,400 a month to give you healthcare insurance. You can buy the same plan on the exchanges for $800. You buy that healthcare plan and I'll pay half of it. So now I'm going to pay $800 instead of $1,400 essentially. So what can happen with the public option is it could slowly become a single payer private healthcare plan. So that's that one approach. Of course, you had an approach like with Bernie Sanders, who's saying, the heck with this, let's just go with it. Let's do single payer. And so you have his plan. So yeah, I've communicated to politicians, but they haven't shown much interest in this. I would encourage them to read the book and take a look at the plan, because I think, as I said, it spreads the cost of healthcare across the entire economy. And by doing that, it really brings costs down. And the way I do that is, as I mentioned, was what some people call a value-added tax. Basically, it's a tax on all goods and services. But the more financial exchanges that you have, the more revenues that you generate through that process, the lower the tax can be. And I'm suggesting that we have a tax that generates enough revenues not only to pay for healthcare, but to pay for other facets of medical care in this country. For example, it would also include a single-payer malpractice insurance, so that the physicians, rather than having to go out and pay lots of money for malpractice insurance, would have one single plan. Every physician in the United States would be covered under that plan. Because they're all covered, the cost for that plan would be less for physicians. So I think that would be a selling point for the medical establishment. So you'd have that. You'd have money that would help defer the costs for training of physicians and nurse practitioners and nurses and other healthcare professionals, so that they're not burdened by the cost of healthcare. I remember, as a story that I tell in the book, where I went to work one day and I saw this brand new shiny red convertible sports car. And I went into the medical center building and I walked up to the physician there and I said, "I guess you've paid off your medical loans." And she said, "Yeah." I said, "You got a new car?" She said, "Yeah, I paid off my loans." So yeah, the physicians, they're stuck nowadays with literally hundreds of thousands of dollars in healthcare, medical loans. And so one of the things that I see in my plan is it would help bring those costs down, so that when they come out of college, come out of their medical studies, they wouldn't be burdened with their medical loans. So there would be additional expenses, but there'd be a wide range of revenues. One of the revenues that I have put in there is the 5 cents per bullet tax, surtax. And basically, I don't think we're making much progress in terms of reducing gun violence in this country, but there's a cost to gun violence. We have about 33,000 suicides a year by guns, about 11,000 homicides by guns, and an equal number of people that are injured each year. So you have about 85,000 people a year that are seen in hospitals for gunshot wounds. And so my idea is that that 5 cent per bullet tax would go back to hospitals to underwrite the costs of treating gunshot victims. So we're talking about hundreds of millions of dollars a year. And it's not just the hospitals. I've seen people, who have been experienced gunshot wounds, and they spend the rest of their life in rehabilitation. They could be, they can be paralyzed from a gunshot wound or lose major organs. So this would help defer those costs as well. So I've recommended those kinds of things, surtaxes, higher taxes on, I guess what we would call sin taxes. So there would be a very low tax on food, but a lower tax on foods that the FDA says are essentials, healthy foods, and a higher tax, say, on foods that are high in carbohydrates, that have high fructose.
You're trying to incentivize that healthy living within the whole tax system in and of itself. That's the first time I've heard of an idea like that.
Well, it's worked somewhat with smoking. We have seen smoking go down because they keep raising the taxes. You do reach a point where you reach an equilibrium where you keep raising the taxes, it doesn't have an effect on smokers. But I think we can say to folks, look, if you want to eat all this high, fructose corn syrup, that's your choice. But you're going to pay a little bit more because down the road, it's going to contribute to healthcare problems. So you're going to also help contribute to the treatment that you're going to need 20 years from now when you have that heart attack or you get diabetes from eating these foods. And also recommending a tax on financial exchanges. There's been some evidence that if you tax, like when you're buying and selling stocks, for example, if you put a very, very, very small tax on that, even a quarter of 1%, there are so many tens of thousands of exchanges that go on every day that it generates huge amounts of revenues, even though the costs are very, 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 very small. So I think we can create a system where we generate a lot of revenue. And that's really important too, like in times now where we have high rates of unemployment. So you're going to have more people putting demands on a system with less revenues coming in. So you also want to have a system that has reserves so that you're generating large amounts of money, but you also have reserves for ups and downs in the economy. And I think the system that I'm laying out there in terms of revenues really can do that.
Yeah, so this has been a great conversation. I feel like the last question I have, unless you have anything else you really want to add, is just with your conversations with people about the book, what has been the response that you've seen just from like people in your audiences, people online? Do you feel like people are hearing you, or do you feel like you're getting valid criticisms? Do you feel like you mostly get trolls? Like, what have you seen as a response?
Haven't seen trolls. It's an interesting thing because I don't think the concept of universal health care is a big issue at this very moment in terms of all the things that are going on in this country. And
I mean, this is like a very unique like moment of everything is clustering together in a chaotic and like dystopian way, though.
I was watching the evening news today, so they had Trump's Supreme Court nomination, Ruth Bader Ginsburg's burial services, memorial services, the election, tornado.
Probably stuff about Breonna Taylor.
Breonna Taylor, Black Lives Matter, protests, law and order. We have a lot on our plates nowadays. And so I think in terms of universal health care, the emphasis isn't there the way it might be, particularly at a time right now. Where I am hearing something about it in the news is in Trump's Supreme Court pick, because there is, before the Supreme Court, legislation to abolish the Affordable Care Act. And if that were to happen, it's an interesting thing. On the one, again, talking out of both sides of his mouth, Trump has said, he don't worry about it. Pre-existing conditions will be covered. Don't worry about it. On the other hand, his administration is in there fighting to have the Affordable Care Act abolished, including its protections for pre-existing conditions. So, if it were abolished, it would have a ripple effect through the economy in terms of numbers of Americans losing their health care insurance. And so I think if we look at it from today's standpoint, I think that's where we're seeing it.
It'd be catastrophic.
Yeah, but we're not. I don't think you're seeing it. And the other thing too is, and I think this is really important for people to understand, is that when we have discussions about things like universal health care, the media covers it as if it was a football game. So they'll cover it. Well, unfortunately, so the Republicans do this, and you get a lot of coverage about what the Republicans are doing. And the Democrats do that, and you get a lot of coverage for what the Democrats are doing. But what you don't get is a conversation to say, well, what do we mean by universal health care? Why is or isn't this socialism? The plan I'm proposing is not socialism, even though it's being called, a lot of people on the right call any form of universal health care socialism. It's not socialism. Medical practitioners will still be private practitioners. They'll do, in hospitals will be private enterprises. It's not socialism. It's going to replace the health insurance market, but that's because it needs to be replaced in terms of cost effectiveness. But other than that, it's not socialized medicine.
Yeah, can we dig a little bit deeper into that? Because I think that's a really profound point that you're making right now that can be like elaborated on and would shift kind of how the conversation about this goes. Because I feel like a lot of people, even who support universal healthcare, view it as a socialist thing. So can you speak more about how it isn't socialism and why it isn't?
Right. Well, the way that I see universal health care would be like any other public service. When you turn on your drinking water, you don't think about where that water is coming from. You just know it's clean. And you know it's clean. You don't think about the fact that you are actually paying for it. Through your taxes, you're paying for water purification. You're paying for sewage treatment. So the way I see universal health care working is quite similar. You can, like I mentioned before, you go in, you hand in your insurance card, they scan it, and that's the end of it in terms of any kind of fiscal exchange, and then you get that service. So so it's a public service. Okay, there are lots of public services, okay? And that's what socialism basically is. Socialism is when the people operate the delivery of the manufacture of products and delivery of services. And how do they do that? They do that through the government. So the government takes on the role of providing products and services. Okay, so examples of that would include public education, the police, the fire departments, as I mentioned, sewage and water treatment, the military, highways. I mean, we have what's called a mixed economy, which is basically we have some things where the government does things quite well, and so we pay our taxes and they deliver service for us. Some things where the private sector does things quite well, and we pay them, they charge us money, we pay them, and they deliver the service or give us a product. And there's some things where they do things well together. NASA is a really good example of where the government pays for services. They purchase the rockets from the private sector, like SpaceX. They send them, the rockets up. But the taxpayers' money is being used for that. So we have right now a mixed economy, and mixed economies are healthy economies. What Republicans want is they want to minimize government and they want to maximize the private sector. What you see when that happens is you're out of balance. The economy comes out of balance. And when the economy comes out of balance, that's when you start getting things like income inequality, where some people have a lot of money and lots of people have very little money. So what we really want to work towards is a mixed economy, which has worked so well for this country. And that's part of the problem. People don't understand that we have a mixed economy. When you hear a Republican talk about the private sector and how great the private sector is and how wonderful entrepreneurship is, and where will we be without Amazon and whatnot because of Jeff Bezos being a great entrepreneur and now all this, I'm fine with that. But I don't want Jeff Bezos running my clean water plant. Okay? And I don't think Jeff Bezos wants to be in the role of running, water purification plants. So there's a role for government and there's a role for the private sector. And unfortunately, too many Americans don't understand that. So when we talk about universal health care being a system where it's an example of a mixed economy where the private sector is actually providing health care, but we have a single system for collecting the revenues and paying the private sector, which is government operated, that is not socialism. For socialism, those doctors would be working for the government. And I speak from experience because I spent the majority of my life working in state psychiatric hospitals as an administrator. I was paid as a state employee. I worked for the state. My salary came from taxes. My benefits came from taxes. The doctors were on the payroll, were paid. That is socialized medicine. That's not what I'm recommending. So I think that's really important for people to understand that. And that's not the conversation that we've had. And that's why I was going back to the way the media covers it. They'll cover the arguments that the parties are making for it, but they won't cover the substantive information that explains that, no, universal health care is not socialized medicine, and here's why it's not socialized medicine.
And was Bernie Sanders advocating for a socialized medicine or a single payer system then?
He was advocating single payer. Where I and Bernie would disagree was on the way he wanted to generate revenues. He had a plan that would put more taxes on the wealthy and more taxes on employers. And I want to get away from that. My plan takes employers out of it entirely because I want employers not to have to worry about paying the healthcare costs of their employees. Okay? I want them to worry about running their businesses and not being a healthcare insurance provider.
Yeah, that's just not a responsibility that's on their table anymore. Yeah.
Right. And I think the more that the private sector hears that argument, I think the more that they're going to be in favor of universal health care. And it'll improve their profitability. They won't have to be dealing with all this. They won't have all the forms. And that's another thing, when they may be getting a tax break, but there's a lot of paperwork that goes along with that tax break. because they also have to collect taxes for Medicare and Social Security and all the other kinds of things that they wouldn't have to be doing, at least as far as the Medicare, that they wouldn't have to be doing. They wouldn't have to be paying towards workers' compensation insurance, because there would no longer be workers' compensation insurance. If you're injured on the job, you go to see your physician or you go to the hospital, and your national health care insurance is going to take care of that. So for the employer, there's a tremendous incentive to go into the plan like I'm presenting here. And that's why, when I was looking at, well, what will help sell this plan, I think part of it will be that consumers will get tired of the high cost of healthcare. And I think employers will be tired of the high cost of healthcare. I don't think the American Medical Association, which has had a long history of opposing universal healthcare, I don't think they will be opposed to it, because their doctors are getting sick and tired of doing all the paperwork that goes along with healthcare insurance. So I think there's actually is a change in this country, but I think the most important change will actually be from the private sector. They just have too much to benefit from this plan. And I concluded the book saying, if you're the owner of a private business, do you want to be paying all these things and help the private healthcare insurance and basically subsidize the private healthcare insurance industry? Or do you want to be making profits in your own business and not have to worry about these things? And I think when the private sector hears that message, they're going to start saying, I don't have to be, I can, the private insurance industry, they're private enterprise, I'm private enterprise, but I don't have to be on their side. I have to be on my side and take care of me. That's where conservatism will work real well. The individual saying, I want to make more money, I want to get ahead, and I want to do this by not having to pay for all these costs.